Assalamualaikum and a very good morning. I'm Dr. Zeti binti Salmuna Elias Ayub from Department of Microbiology, University Science Malaysia. Today's lecture is about toxic shock syndrome. Have you ever heard about what is toxic shock syndrome? These are the learning outcome of today's lecture. You must be able to differentiate and define the toxic shock syndrome, able to differentiate types of toxic shock syndrome, and able to discuss on laboratory diagnosis and management of toxic shock syndrome. These are the content of my presentation, which include introduction, streptococcal and staphylococcal toxic shock syndrome, pathogenesis, lab investigation, management, and also references. Toxic shock syndrome is an acute multi-system toxic-mediated illness often resulting in multi-organ failure, and it is a most prominent expression of a spectrum of disease caused by toxin-producing strain of Staphylococcus aureus and Streptococcus pyogenes, which is a group A streptococci. And it is approximately about 8 to 14% of invasive group A streptococcal infection will also develop toxic shock syndrome. It was estimated about 3.5 cases of streptococcal toxic shock syndrome per 100,000 population, and 80% of patients have clinical signs of soft tissue infection such as localized swelling and erythema, and in which 70% of patients progress to necrotizing fasciitis or myositis, and which require surgical debridement, fasciotomy, or amputation. And streptococcal toxic shock syndrome is very virulent with up to 70% mortality. These are the risk factors for toxic shock syndrome, which include disruption of cutaneous barrier either by laceration, burn, surgical procedure, decubitus ulcer, intravenous drug abuse, and bites, which provide cutaneous portals of entry. Certain viral infections such as chickenpox or influenza can disrupt mucosal and anatomical barrier. Childbirth may compromise the integrity of the uterine mucosal barrier, which allow the entry of group A streptococci into this normally sterile site, and as NSAID will modify the sign and symptom of streptococcal infection. Based on 2010 case definition for streptococcal toxic shock syndrome, it is an illness with following clinical manifestation such as hypotension and multi-organ involvement characterized by 2 or more of the following: either renal impairment, coagulopathy, liver involvement, acute respiratory distress syndrome, generalized erythematous macular rash that may discommit, soft tissue necrosis. Probable streptococcal toxic shock syndrome is a case that meets the clinical case definition with isolation of group A streptococci from a non-sterile site, and confirmed case is a case that meets the clinical case definition with isolation of group A streptococci from a normally sterile site. For non-streptococcal toxic shock syndrome, case definition 2011 include clinical criteria that such as the fever, rash, desquamation, hypotension, multi-system involvement, either 3 or more of the following organ system, and include laboratory criteria for diagnosis, which is blood or CSF culture positive for Staphylococcus aureus with negative serology for Rocky Mountain spotted fever, leptospirosis, or measles. For probable case for non-streptococcal toxic shock syndrome is a case which meets the laboratory criteria and in which 4 of the 5 clinical criteria described above are present, and a confirmed case is a case which meets the laboratory criteria and which all 5 of the clinical criteria described above are present, including desquamation, unless the patient dies before desquamation occurs. Okay, staphylococcal toxic shock syndrome first reported in 1978 and has shown increase in incidence in early 1918 in the US, and it can be divided into menstrual and non-menstrual type. And as we can see, the non-menstrual related staphylococcal toxic shock syndrome has 2 to 3 times higher mortality rate than menstrual type. So, menstrual type toxic shock syndrome start within 2 days of the beginning or end of the menses, more likely in women using highly absorbent tampon and keeping a single tampon in place for a longer period of time. And staphylococcal toxic shock syndrome T1 is responsible for about 95% of menstrual-related toxic shock syndrome. The risk factors are such as vaginal colonization with toxigenic strain of Staphylococcus aureus, production of TSST1, penetration of sufficient concentration of TSST1 across the epithelium to cause the disease, and absence or insufficient titers of neutralizing antibody to the toxin, which is seen in 90% of patients with menstrual toxic shock syndrome. For non-menstrual toxic shock syndrome, account roughly about 30 to 50% of all cases of staphylococcal toxic shock syndrome, and 1/3 involve men, and it usually complicate the use of barrier contraceptive, surgical and postpartum wound infection, burn, cutaneous lesion, osteomyelitis, and arthritis. A special feature of wound colonization is that the affected tissue often do not appear inflammatory. This is believed to result from the toxin itself, which is able to prevent the influx of professional macrophage. For pathogenesis, in toxic shock syndrome, the toxin release acts as superantigen, which does not require processing by antigen-presenting cell, but instead it interacts directly to the T cell by using the invariant region of the MHC class II molecule. So, in patients with toxic shock syndrome, up to 20% of the body T cell can be activated at one time, causing release of the cytokine storm and cause multi-systemic disease. How can you differentiate between toxic shock syndrome caused by Staphylococcus aureus and streptococcal toxic shock syndrome? Streptococcal toxic shock syndrome is more common, with tissue necrosis and bacteremia is more common, and with 70% mortality. And the virulence factors were also different. For laboratory investigation, gold standard is culture. However, as we can see here, streptococcal toxic shock syndrome, the blood culture are positive in 60% of cases compared to staphylococcal bacteremia, account only about 15% cases in menstrual toxic shock syndrome and only about 6% in non-menstrual cases. And for identification, for streptococcal pyogen, usually the gram cell is gram-positive cocaine chain with beta hemolysis on blood agar, Brachythracin sensitive, PYR positive, lancified group A, bioxide strep test, and catalase negative. However, for Staphylococcus aureus, the gram stain showed gram-positive cocaine cluster with coagulase positive, catalase positive, yellow colony on mannitol salt agar, and linas positive. These are the laboratory features for Staphylococcus aureus. We can see the colony on blood agar is big greenish with hemolysis, and the gram stain showed gram-positive cocaine cluster, positive catalase test, and positive tube coagulase test. For Streptococcus pyogen, usually on blood agar, we can see pinpoint beta hemolysis with gram-positive cocaine chain, and strep oxide grouping is positive for group A. For management can be divided into supportive therapy, which include fluid resuscitation, vasopressor, ventilation, ICU care, surgical debridement, and the source control is mandatory, and it is critically important to be early. It must be early. Antibiotics play an important role. Adjunctive therapy may aid in the management of the toxic shock syndrome. For antibiotic, the aim of antibiotic is mainly to decrease bacterial load and toxin production. Empirically, we can give clindamycin plus either carbapenem or penicillin plus beta-lactam inhibitor such as piperacillin-tazobactam or vancomycin. In confirmed streptococcal toxic shock syndrome, we can give benzyl penicillin or penicillin G and clindamycin. For confirmed staphylococcal toxic shock syndrome, for methicillin sensitive, we can give clindamycin plus cloxacillin. For methicillin resistant, we can give clindamycin plus vancomycin. Clindamycin is a protein synthesis inhibitor and a bacteriostatic drug. It has 5 important actions which suppress the bacterial toxin synthesis, and the efficacy is not affected by inoculum size or stage of growth. It facilitates phagocytosis of strep pyogen by inhibiting M protein synthesis. It suppresses synthesis of penicillin binding protein, enzyme involved in cell wall synthesis and degradation, and it has longer post-antibiotic effect than beta-lactam. What is the clinical value of penicillin? It is called eagle effect, which is paradoxical reduce of antibacterial effect of penicillin in high dose. As we all know, penicillin has antibacterial action against penicillin binding protein. Early in the stages of infection, organisms grow rapidly in vivo, but the numbers are rather small. With delays in treatment, higher concentration of group A streptococci accumulate and growth begin to slow to a stationary phase, and the loss of certain PBP during stationary phase growth may be responsible for the inoculum effect. And failure of penicillin in both experimental and human cases of severe streptococcal infection will complicate the condition. Other proposed mechanisms include induction of microbial resistance mechanism by high drug concentration. For adjunctive therapy, IV immunoglobulin to boost antibody level via passive immunity is useful in the setting of overwhelming infection. The mechanism is to neutralize streptococcal toxin, inhibit T cell proliferation, tumor and release of pulmonecrosis alpha and interleukin 6. High-dose corticosteroid may also improve outcome, as shown in isolated case report, and monoclonal antibody. It may become a strategy to inhibit or neutralize cytokine, especially tumor necrosis factor alpha, which is important mediators of shock in streptococcal toxic shock syndrome. Okay, and then these are the list of preferences for this lecture. Thank you very much, and Assalamualaikum.